Well, thank you for the opportunity, and I'm sorry I missed you last year. I'm Dr. Bruce Scott. I'm actually an otolaryngologist in Louisville, Kentucky, still in private practice. Yes, those still exist. Not very many of them, but they still do exist. Sorry I couldn't be with you this morning. I actually was taking care of patients. How many of you had the opportunity to hear Dr. McCullough's speech last year? A few number of you. Bobby is articulate, intelligent, handsome, not as much as I am, and not as humble as I am either. But I got to tell you an interesting story about Bobby. So Bobby talked to you guys at about the same time of year last year. In November, he was presenting at a different conference, and suddenly he lost his words. He stood there for a period of time saying nothing, and many physicians in the room were concerned that he had had a TIA or a stroke. He's a young guy, he's younger than me. So by definition, anybody younger than me is young, right? So they took him to a local emergency room and they evaluated him, and they said there was no stroke, but they recommended that as soon as he gets back to his hometown of Flint, Michigan, a small town with not a lot of medical resources, that he get checked out. Bobby went to a local physician and they did an MRI, and they discovered an 8-centimeter tumor in his brain. The world came crashing down for Bobby. He was in Flint, Michigan. Now, Bobby has a lot of resources. He's a physician, he was the president-elect of the American Medical Association, and he used telehealth over the next couple of days and weeks to connect with neurosurgical specialists at Duke, at Stanford, at Mayo Clinic, and several other places around the world to find the physician who specialized in the diagnosis that he had. Ultimately, the good story ends that Bobby went to the Mayo Clinic. He had surgical resection of what turned out to be a grade 2 astrocytoma, which is a relatively benign malignant tumor. He had the majority of it removed, and now he is on medication. And believe it or not, about 6 weeks after his surgery, he was back at a conference with me, on a podium with me, giving speeches, and he is fulfilling all of his duties as the president of the American Medical Association, as I'm now the immediate past president. Bobby's journey showed the fact that telehealth and connectivity has incredible opportunities, but Bobby has also realized that if he were not a physician himself, the president-elect of the American Medical Association, with relatively good resources, people in his own community of Flint, Michigan, weeks later, after he'd had surgery, would probably still be waiting for an appointment with a doctor and would have to be fighting for prior authorization of the MRI that he needed, and certainly would not have had the resources to travel to the Mayo Clinic to have a person who didn't just do these tumors once or twice a year, but once or twice a week. Those are the sort of situations that we need to make available to everyone. So I start with that story, and I want to also talk about the American Medical Association, which I have the honor of being involved with for about 30 years. All of you probably have an image of the AMA. Yes, we are a major political advocacy group, but our focus is on promoting the art and science of medicine and the betterment of public health. And indeed, public health, whether it was the ravages of years ago misinformation and quackery that actually resulted in the creation of the AMA, or things like smoking, or the recent pandemic, we've tried to lead with basically 3 things in mind. Removing obstacles like prior authorization that prevent physicians from providing care, tackling chronic disease, and driving the future of medicine. As I was looking at my slides that I use in other talks, I said, wait a second, telehealth is a pathway for all of these, as we need to eliminate those obstacles, particularly for people living in rural states. We have a problem in our country that is already existing but is getting worse because we have an aging population, increasing chronic disease that we really have not gotten a handle on. Our medical system right now is great at fixing your broken arm. We're really good at creating a new blood vessel for your heart through a cabbage, but we're not very good at preventing the heart attack or preventing the broken arm, trying to deal upstream, if you will, with chronic disease. And the situation, as you all already know, and I know it's been detailed to you today, is worse in rural America. One of the things that I say when I go to talk to legislators is, you realize that there is as many people living in rural areas as there are in the 5 largest cities in the United States. Can you imagine legislators ignoring New York, Atlanta, Houston, Los Angeles, and the people who live in these cities? No way. They would never get elected. But yet, flyover country, which we live in, have greater problems and greater access to care. But in the midst of this projection of an aging population and growing chronic disease, AAMC has estimated a shortage of over 80,000 physicians in the coming year. And the situation is worse right here in Kentucky, where we're estimating a shortage of over 100,000 physicians over the next 10,000 physicians over the same period of time. Already, millions of Americans do not have access to obstetrical care. They don't have access to specialist care. With average in rural areas of 30 specialists per 100,000 people compared to over 250 specialists to the same 100,000 people in urban and well-served areas. You heard earlier during John's talk about rural health closes across the United States. Before House Bill 1, the big, beautiful, bad bill, we actually already were worried about 136 hospitals closing in the next couple of years. Hospitals are already closing, and on top of all this, we've seen a decline in the number of rural students applying for medical school, and thus a decline in the number of graduates from medical school who come from rural areas. And data is very clear that these are the people who are most likely to come back to provide care in rural areas. So what's part of the answer? Well, it was pressed upon us during the pandemic when people were not allowed to come in person to see their doctor, and physicians embraced telehealth. Patients embraced telehealth. And AMA worked with Medicare and the federal legislation to say, you know what, we need to pay for this, we need to make this available, and we need to make some changes in the rules that said that people could do this from their home, and that people could do this without having to go to a doctor first. And these changes were great, and they were embraced, and they were temporary. Now, we've been successful in getting Congress to renew it in 2023 and renew it in 2024. And I don't know how many of you all know, and I'll talk a little bit more about this later, but there is a cliff approaching us in just a few days. Telehealth payment is scheduled, and the flexibility is scheduled to end September 30th, unless there is federal action. I'll get back to the federal advocacy in a moment. But we've been pushing for permanent change because some of the things I'm going to talk about require an investment. And is your practice or your hospital, your program going to invest in something that has a 1-year payment schedule and an unknown future beyond that? This is what we're trying to convince our legislators of the importance. Now, at the same time, physicians, including myself, had never done telehealth. And we needed instructions. How do we do this? How do we make it work with HIPAA and the privacy rules? And how are we going to make this work with patients who don't understand how to do this either? And the AMA provided resources to physician practices to go through it step by step. And these resources were embraced by physicians. Look at this slide here. This shows you before the pandemic, the utilization of telehealth and AI by physicians. You see a peak in 2020. Now, in 2023, we came down from that peak, but in 2024, we're seeing numbers go back up again. And for psychiatrists, over 92% of them report utilizing telehealth, and 67% say that they use it on a daily or a weekly basis. So telehealth is part of our medical care system at this time, but we need to keep it that way. That requires federal advocacy, and I have an ask of you. Contact your legislators, your senators, your representatives today, and tell them that we need to make sure that telehealth will survive. There is a bill It is pending right now. And believe it or not, it has 69 Senate co-sponsors, bipartisan. There's nothing in Washington, D.C. that has bipartisan support right now except telehealth. But yet it's trapped. The Republicans, in their continuation resolution, have suggested we continue it until November. Well, the Democrats have pushed back mostly on the continuation of the tax cuts, but on the telehealth as well, and said we want it to be permanent. I don't know if we're going to get that, but we need to continue to work, and we need to make sure that the rug is not pulled out as of September 30th. The Connect bill, which is already pending, removes those geographic restrictions. It allows audio, which I'll talk about a little bit more in a moment, and it removes the inpatient requirement. So on a federal level, this is what the AMA is fighting for, and I encourage you all to get to be part of the fight. But a lot of the activity occurs on a state level. And these are kind of the issues that the AMA sees that need to be addressed regarding telehealth. First of all, payment. Yeah, doctors don't like to talk about payment a lot, but it is necessary for us to get paid for the services that we provide. Secondly, is licensure rules. If it's illegal with the state licensure to do something, that's a burden. Network adequacy. Now, I mean this in two ways. Number one is internet adequacy, but the other thing that I really mean is physician adequacy. And with Medicare Advantage plans, Medicaid Advantage plans, cut physicians from their profile, from the people who are able to participate, you lose your doctor, and sometimes you didn't even know that you were losing your doctor. And then I want to spend a little more time talking about expanding the perspective of telehealth and the digital future that perhaps is an answer for some of the problems that I detailed in my first slides. Now, this is kind of good news. All of the dark purple and then the light purple states, including Kentucky, are states where there is relative payment parity. Yes, as John said, Kentucky was the first state to have our legislature mandate that Medicaid and commercial plans paid for telehealth services. The AMA is pushing, and in most of the states we've been successful. Our model legislation really simply puts it like this. It should be on the same basis and the same extent as an inpatient visit. Pretty straightforward. We know how to code and bill for our inpatient services. It should be the same for telehealth. Licensure is an issue. We've looked at licensure in terms of a national licensure, and the truth of the matter is that state by state have different licensure rules, and that's important so that we can continue to ensure the quality of care that every individual physician is providing. We all are aware of problems with physicians losing their license and potentially going to another state and losing their license there, et cetera, et cetera. Those are the bad apples that we want to make sure we weed out, and state licensure boards are how we do that. But we need to overcome the barrier because many times the patient is in a different state than the doctor, and yet the Federation of Medical Licensure Boards insist that the physician be licensed in the state where the patient is located. In effect, that's where the care is provided, whether that care is being provided over a telephone, over a video screen, or over an inpatient visit. So one of the ways around this is what's called the Interstate Medical Licensure Compact. The AMA has supported this, and it's actually been pretty successful. 42 states have now embraced this. Now, it's not immediate. You have to prove that you're qualified, but it's a simplified process. State licensure in Kentucky, we just had a new doctor join us in July. It took us 7 months to get the physician who's very qualified to be licensed in the state of Kentucky and on the panels that we wanted to get him on. And that's too darn long if you're trying to do telehealth, particularly if you're trying to do it in multiple states. Plus, it's expensive. You got to pay the licensure fees. Legitimately, there's a lot to go into it. So the compact allows states to say, look, you're okay if you're in Kentucky. We'll do a simplified version of that form in Illinois, and we're going to give you a contract here. It's interesting that they have actually processed 150,000 new licensures, and the majority of these have been for people to do telehealth. And many of these physicians are now licensed in average of 3 states, but many of them in multiple states. One of the other options are exceptions. For example, many states make an exception for people living across the border. I have an office in Indiana and an office in Kentucky, Tennessee, Kentucky, etc., around the nation. A lot of people cross borders. Contiguous states often provide reciprocity. There's also exceptions. During Katrina, we figured out that we should allow physicians to immediately become licensed to go provide emergency care in the New Orleans area. Clinical trials. Patients travel from around the United States to join clinical trials, and examples like Bobby McCullough, complex cases. Cases where I want to pick up the phone and talk to a doctor in Boston, but I want him to also be able to connect with my patient in rural Kentucky. And we can now get exceptions to allow those things. A few states have put in rules that are pretty restrictive. There's a couple of states that say, okay, you can do this 10 times a year or with 10 patients. And that's not really the sort of flexibility we're looking for. Finally, some states have exceptions for psychiatric care. Many states have exceptions now for urgent or emergent mental health care in the situations where suicide is considered as an option. And thank goodness we have options in that regard. And then finally, there is federal exemption to the licensure requirements. Audio only. I can tell you I'm already using audio only with some of my patients in Kentucky because they don't have internet, and some of my older patients, including my own mother, don't know how to use FaceTime or to get on a computer, but she knows pretty well how to use a telephone. Yes, her telephone still has a cord attached to it, but she knows how to use that telephone. She is unable to push the little buttons, when it says dial 0 or 1 or whatever. We're trying to move her gradually. I know it is 2025. It was interesting, you showed the antique fax machine. Do you know that physicians' offices use fax machines every day? You know why? To get prior authorization for the care that you need from your insurance companies, because they insist upon us using fax machines in many cases. In fact, Cigna just came out with another thing the other day explaining why they like fax machines, because it provides HIPAA compliance. I had a student rotating in my office, a pre-medical student, the other day, and he said to me, Dr. Scott, let me see if I got this straight. You want me to print this material out of our electronic medical record and then put it on that machine and dial a phone number so it can go someplace else, and then they're going to scan it and put it into their computer? And I said, yeah, that's right. And he said, that doesn't seem to make any sense. The same day, I did a robotic surgery with him watching, and it's kind of like Fred Flintstone living next door to George Jetson. All in the same day. Some of y'all probably don't even know who those people are because you're too young. That's okay. But it's an example of, we've got to move forward. And part of that is getting our patients to have video, but part of the reality is that we need to be paid and it needs to be covered for us to provide the care through audio only. I want to use the minutes I have left, if I have any left, to talk about actually merging telehealth into the future. And I'm going to be proud to tell you that Kentucky is already there in many of the ways that Dr. Langfeld talked about. We see increasing use of AI, of digital medicine by physicians. In this slide, simply from 2023 to 2024, you can see increases. Now, most of the increases are in documentation and in electronic medical records and such, but you're beginning to see physicians use AI for diagnoses and for actually care of patients and intake of patients. There's an opportunity for digital technology working with telehealth to actually expand the telemedicine landscape to include a connectivity between touching a patient and care here and care at a remote site. And Kentucky is leading the way. You heard reference earlier to the Angels program. It's been going on for 10 plus years. And we're actually utilizing, as you heard, telehealth, ultrasounds in one location being sent to another location. The anesthesia pre-op team at University of Kentucky for over 25 years has been using telehealth with their patients at a distance in order to do, in effect, their pre-medicine, pre-surgical care with remote stethoscopes that can send the heart sounds to them so they can analyze the breath sounds and heart sounds in Kentucky. The federal prison system works with the ENT doctors here in Lexington, I guess near here in Lexington. You know, it's all east of Louisville for us, you know. It all kind of starts getting blue once you come this way, you know. Anyway, I've been doing that for 20 years, and there's been 300 programs that already exist around Kentucky. So Kentucky's leading the way. But let's be careful. We want to make sure that there's this twin goal of embracing this technology, making sure it's reliable, making sure it actually works, integrating it, but at the same time, making sure that telehealth, telemedicine technology does not replace the gentle touch of a physician, the listening ear of an individual, and the care that is provided person to person, that touch. The AMA likes to use the phrase augmented intelligence rather than artificial intelligence in order to emphasize that human-centered component. There was just an article earlier this week in the New Yorker talking about how AI, they thought, the author had written an article a few years earlier about how AI is going to replace physicians. And they recanted that and wrote an article about why AI was making mistakes and why the physician needed to be there. And while even when AI provided the right answers, there wasn't that delivery of the care that the physician alone and that the physician's clinical judgment could deliver. We know that large language models have opportunities, and yeah, there was a study that showed that the computer was better at answering patients' questions than doctors were, and that they even were perceived to be more empathetic to the patient. But the algorithms cannot replace physicians. Nobody wants their doctor to be an algorithm, no matter what some of the insurance companies would suggest in terms of what their algorithms are able to predict. So one of the challenges, and I went to a big telehealth and AI meeting down in Miami, and the room was a couple thousand people. And everybody was excited about what they were doing, and there were amazing things going on in digital medicine. And everybody agreed that the government was behind in the regulation and that the government needed to regulate whatever it was they weren't doing, but the other people in the room were doing. Everybody agrees that the regulation is far behind, and we need our government to catch up. And we need them to provide regulation to make sure that it's not biased. You all heard a presentation earlier on pulse oximetry. Do you all realize that we've been using pulse oximetry for years? I don't know if this was covered in the talk or not, but we figured out in about the last 3 years that pulse oximetry didn't work for Black patients and brown patients, that it was wrong. And yet we had embraced it and we're using it, and we're predicting that some of these patients had oxygen levels that were significantly lower than they actually were. We need to make sure that the future technology does not just perpetuate the biases and the mistakes that we've made in the past. The tools also present legal challenges. AMA is very concerned and very involved in this. Those who develop the software, those who sell the software, would suggest that it should be entirely the physician who is financially liable for when anything goes wrong. Recently, there was a major cyber attack on a major healthcare company that's an intermediate that disrupted the billing for over a third of the physicians in the United States and released the private health insurance information of millions of Americans. And the company suggested that it should be each individual physician who should contact their patients who'd had their information leaked and tell them at the doctor's expense that this company, multi-billion-dollar company, had had an attack and that it was our responsibility. Well, we fought that in the courts and we made them handle that responsibility. But there have been other legal cases that have suggested that an AI is simply like another tool. It's like a scalpel. And if I, as a surgeon, use a scalpel And the scalpel's not defective in its design, but something goes wrong, that it's me. It's not the manufacturer of the scalpel. And we're trying to say AI and scalpel, not the same thing. Absolutely. Physicians are worried about basically, will it work? Will it work in my practice? And will I get paid for it? And will I get sued? And those are really pretty reasonable things for us to ask. As physicians, I don't know how many physicians in the room? Physicians in the room will remember when there was electronic medical record forced upon us. They will laugh at the pun by saying that it was a problem of epic proportions. As this internet system, this electronic medical system, resulted in your doctor being over here at a keyboard instead of over here taking care of you. Because it was designed without input from physicians and without making sure it actually worked in the clinic. Now, 10 years later, we're getting it to work in our offices, and we're using AI to get that to happen. That's the conclusion of my prepared remarks, and I understand we have some time for questions, and John's going to come back up here, and the tough questions will go to him, and the easy questions will go to me. It's been a pleasure being here with you guys. It was a short drive over, which is quite nice. So I was actually in China last week and just got home from China on Monday, talking to the Chinese Medical Association. And it was interesting, the representatives there from Germany, France, Italy, Bangladesh, Russia. And we all talked about the fact that we have many of the same problems in our healthcare systems. The increasing demand for healthcare, the reality of the finances of the providing healthcare, access and guaranteeing access for our patients. And as physicians, we all share those same goals, is to provide simply the best possible care for our patients. Thank you all. Come on up.